Thank you for joining us today for the meeting of the New York City Health and Hospitals Finance Committee. Today's meeting is officially called to order. For the record, is anyone participating and listening? No. Okay, sorry. I would like to propose a motion to adopt the minutes of the Finance Committee meeting held on May 6, 2024. I'll poll Dr. Katz.
Yes.
Sally?
Yes.
And I vote no. Yes, sorry. So the minutes are adopted. Where did that come from? So the motion's adopted. Next on the agenda, we have a financial update from the finance team. John, if you want to start us off.
Yes. Thank you for your time. Happy new fiscal year. Today is the first day. Yes. Celebration of summer for us. But I think we're doing fine. We closed in May with $616 million or 22 days cash on hand. We reported as of April a net budget variance of a negative $62.2 million. At our last report, our February numbers, I think our margin was a plus 155. So it was like a swing of about $215 million over those few months, which of course gets our attention. But it doesn't really surprise us because, as we talked about, at the last meeting, the disruption with Change Healthcare was pretty dramatic for us, and so we went through our three-phase plan. First plan is we had some pretty nice healthy balances, and we went through those. Margie, Bob, and team stood up new vendor Experian. They've come in, they've established themselves, and we feel pretty good about that. And the third phase is really getting some support from the feds and the state with some transactions that we had, in play with them. But that swing of about $215 million, when we look into the numbers, is really all explained by the Change disruption. And if we look forward into May, we've pretty much got those dollars back at this point. So we feel, we're back into the positive margin. We think the close for the year will be fine for us at about $600 million. I think we're still dust is settling there. So we feel like the system's stable and we're doing just fine despite the disruption. I also kind of find quite remarkable, despite the disruption, our year-to-year direct patient care receipts is up actually $110 million. So despite being down, taking the hit for 200, we're still up on an actuals to actuals basis, which is, just I think shows the underlying resiliency, in the system.
And that number would be higher if the Change Healthcare didn't.
Yeah, if we took the snapshot in May, it would have been roughly $200 million higher. So that all, looks good to us. Feels about right given everything that's in play. Our volumes are good and solid. 1.7% up on inpatient discharges since pre-COVID. 10.6 on the outpatient side, which is really, I think, quite remarkable. Strategic financial initiatives, we'll get a better snapshot of this number, but we fully believe when we look at the end of the year, we'll hit our target, maybe even exceed it a little bit, of $1 billion. And all those areas are doing very well that we focus on. And then behavioral health centers of excellence is something we've been working on in partnership, with the state, the Office of Mental Health, and participating hospital systems in the city. And we got our first allocation of dollars based on meeting these quality scores and benchmarks that you have to hit of 26.8, and our total award amount is $41 million. So there'll be a little bit more coming to us from that effort. So overall, I think things not too bad for us. Systems estimate, as I said, to close at $600 million. The transaction that we've been working on with the state, you've heard us talk about it, the inpatient UPL and outpatient UPL. Again, they go back. We got approval from CMS on the first one. The state's going to allocate those dollars. That's for the previous state fiscal year. And then on the outpatient side, James and folks are just exchanging with CMS on the last round of questions. So we feel pretty optimistic about that as well. It's just a little bit late for our plan. So the three phases are working. The phase 3 just a little late, but it's coming, and we'll feel good for the first quarter. I think we're pretty well set up for the first quarter.
Great.
Moving on to managing risk here. Again, we feel pretty good about these have played out over the course of the year for us, right? Most are green. We're still yellow, recording yellow on the glide path, despite the fact that the nurse glide path has gone exceptionally well. I mean, I don't think we could have asked for a better effort on the part of the nursing staff at both facilities, as well as Yvette and HR team. They've done a real good job focusing on hiring our own nurses, and we're ahead of the target by 360 RNs. As we recall last year, that was a big vulnerability to us financially, and folks have really, I think, done an exceptionally good job on that. Sessional and locum, we're still working on that. We've completed what we call the workforce plan, which really provides greater definition in terms of the types of physicians that we need to recruit for with our affiliate partners. And I think one of the things we'll talk about as a focus item for the FY25 budget, similar to nursing, is replacing locums with our own doctors and bringing in support to help relieve our current doctors that are working a lot of sessional time, bringing in FTEs to replace those hours. So that's one of the things we've really got lined up for next year. The city-state budget, I think it played out, well for us. We did, again, have to absorb $100 million peg in the course of the year. So we've managed to manage our way through that in the close of last year. I think James has news on the city budget.
I mean, the city budget was adopted by the council on Sunday, so just yesterday. So we're waiting on all the impacts of it, but happy to see the budget adopted and go into FY25.
Yeah. So I think there's fine. The state, we're still sorting through the different provisions. I think as the state works on, implementing its budget for 24-25, but overall we feel that it's neutral. There's probably actually some upside into the budget that, again, we'll work with the state and report back on that through the course of the year. Medicaid research playing out very well for us. We have a slide in the back, continue to beat our benchmarks there that were in the budget, and then Change Healthcare. Bob will go through a little bit more of that, but we feel like we have that back in order. There'll be some things that we have to finalize on the back end, like getting remits, but for the most part we feel like new systems in place. We're collecting on what's owed to us from most payers, and you had asked at the last meeting to keep track of that bucket of claims, and we're doing that, and we'll report back to you in terms of what's being left out there to resolve. So we feel pretty good about change as well, despite everything.
Great.
Financial performance.
Okay, sure. So I'll go over these next few slides. So we ended March with a net budgeted negative margin of $62 million. Again, receipts are still exceeding budget despite Change Healthcare, but again, that Change Healthcare did bring us down a bit on the margin. Patient billing revenue is behind target by about 3% due to Change Healthcare. Disbursements are still exceeding budget by $310 million. And that includes expenses associated with temp coverage, affiliation, PS overtime costs, and other increased patient care costs, which we'll get into a little bit more detail in the next couple of slides.
Sorry, Selena, this is ending April, right? Not March.
Yes, April.
Okay, right. Okay.
Sorry, did I say March?
Yeah.
Just in the top it says March.
Yeah.
In that, in the.
It says ended March,
Yeah,
even
yeah,
though the header says.
Oh, okay, we'll
Yeah.
fix that.
Yeah.
Sorry.
Thank you.
Okay, next slide. Again, so cash receipts, we'll go through the revenue first. So again, cash receipts are still 3% ahead of the budgeted targets. Inpatient and outpatient volume is ahead of target despite cash being below target by $121 million. Risk pool performance, again, same performance we had last time. We're still ahead of target, primarily due to the PMPM coming higher than what we anticipated in the budget, as well as some prior year reconciliations. Another area where we do have a surplus is in other revenue. It's largely driven by our UPL, normal UPL, not UPL conversion, coming in higher than the annual budgeted target. Any questions before we
Once we get the UPL conversion done, will there be normal UPL still? There will be.
Our goal is to take the UPL dollars that we get on a fee-for-service basis that comes to us as a lump sum, and embed
Into the rates.
into the rates.
Yep.
And there's a state plan that's awaiting, a submission to CMS on that. It slipped a little bit, but that is certainly, part of our agenda is to try to build those dollars into our, and it'll help us, right? Because some of these, what makes it difficult is some of these are, the last one we have outstanding is 2022.
For fee for service,
Yeah.
2023.
Yeah, 2023. So we're still waiting for payment on
A year. of
services that we
ago.
provided in 23.
Right.
Right. And we'd like to just get those dollars as we're providing the service. So.
Makes sense.
Okay, next slide.
Thank you.
So on the expense side, a couple of things to point out here. We do have a PS negative variance of 83 million, largely driven by overtime. However, we do expect that variance to improve once we continue to implement the proper budgets associated with staffing models. So we have the surgical model that is being rolled out, labor and delivery, CPAP, which is our outpatient behavioral health on the ED side. All of that is going to make it into the budget. Right now, we do have them already in for 25, but in the close, we'll also right-size FY24's numbers with the latest models. On the temp side, we are finally starting to see the cash keep up with the story of the temps being released. So you can see that in the last 2 months, the average weekly payment that we're paying for the temps is down 43% prior to the first half of the year. So we're definitely tracking our temp budget target by December of 2024, FY25. So we're definitely tracking to get back to budget. Other discretionary spend, we are still over target there a bit, largely driven by inflation rates coming in at a higher tick than what the budget has been able to keep up with. And so we're working in the background to kind of figure out where we can right-size that as well. And obviously affiliations too is the story that John went through earlier, where we have our sessional and locum usage a little bit past target, but again, right-sizing that in partnership with the workforce plan and the CMOs and getting that to the right size as well. Any questions, comments?
Yeah, I'm just curious on the affiliations. Are those additional revenue that we've kind of built in that the affiliates can earn, or is it overruns by the affiliates?
That's a good question.
It's a mixed bag.
Yeah, no, we've looked at that, trying to figure out what is the true cost of the additional sessional and affiliation spending.
Mhm.
And we do factor in that as you're bringing in additional, providers, that it will drive additional revenue.
Right.
And in some cases for the affiliate, it drives additional revenue for them as well for the work that, the physician's providing. So where the savings opportunity, though, is that we generally pay our affiliates, kind of twice. Same situation we had with the nurses, right? We pay them twice of what we think is a reasonable salary. So the savings here really comes from substituting the affiliate contract, which is very expensive for certain types of physicians, to just having our own. So that's where we see the.
But John, that's the words are getting confused. You mean that the cost of sessional or locums is twice
Yeah.
what the cost would be
The
if
cost-
we hired someone our own. It's confusing because
Yeah.
in terms of doctors, the only true our own are doctors who are at Kings County
Oh, yeah.
and a few of the other hospitals, right? But we also think of them as our own if we hire them through the affiliate and they're a full-time person.
Right.
Right, as opposed to a locums. So we also do locums through affiliates.
Right.
And we do sessional through affiliates. And the most efficient from a cost point of view is permanent
Yes.
through us or through an affiliate.
Yes. Yeah, I used the us and Broadway. Yeah.
Well, it's very
It's permanent versus temporary.
It's permanent versus temporary.
Right.
And there's sort of three levels. There's permanent, there's sessional, and then there's locums. And that you go higher and higher. So sessional are generally our employees working additional hours. They're getting a better rate than regular.
Oh, okay.
But then there are the the locums, which
Not
are
ours.
not ours, much higher, where the affiliate is entering into a contract with a locums to provide the additional service, and those are the most expensive. I think they'll also, from talking to the clinical people, there's always some bumpiness in going from nurse registry to nurse permanent positions, because in that bumping, it will turn out sometimes that we were a little overstaffed in the registry, or what we think the staffing plan is actually understaffed, right? And so it's not 100%, because tracking of the registry is a little, it's not as tight as tracking of actual people. So a hospital may have said, I need 97 nurses, but it may turn out that the staffing plan was 92 nurses. And then you have to go and figure out which number is correct, right? Because we're always focused on, we're clinical operation, we want to provide the correct number of nurses. We're not trying to save money, we're not trying to spend more money, we're trying to, so then we have to go back and say, okay, so is it 92 or is it 97? And sometimes the lower number is right, and sometimes the higher number is clinically right. And so that's yet another sort of blurring as you move from, I mean, ultimately having our own makes budgeting much clearer and more accurate. Anytime you go onto registry, it's different.
Right, and that's where the models are definitely helpful on the nursing side. Then they give us a sense of like, what's the true, right,
Correct.
clinical, right, issue.
And we're doing that now for physicians in a much deeper way than Health and Hospitals has ever done.
Yes.
All the physician hiring has been by tradition, which means each hospital is a little different based on its tradition. It may have always had 3 anesthesiologists on call. This one may have always had 2 anesthesiologists on call. No particular reason, and also often no particular science to tell you whether you should have 2
or 3,
anesthesiologists on call at night or 3 anesthesiologists on call at night. But what we're trying to at least get to is agreement on this many patients equals this many doctors, just as we're doing on nursing, so that there's less variability, or at least we can explain the variability that there is.
Yeah. No, again,
Predict based on what
Census.
Right, exactly.
Right. I mean,
Census, yeah.
in an ideal world, because of our clinical focus, everything would be based on census, right? You have more patients, therefore more doctors, more nurses, and more revenue to pay for it, right? You have less patients, then you go down. But that it was not at all the history 6 years ago. It was 6 years ago, everything was fixed staffing till the nurse plan, right? So this number of people wasn't all based on history and not at all based on, so if census went up, then people were wildly understaffed. And if census went down, we lost a huge amount of money because people weren't productive.
But how do you keep the right mix if you're going to permanent and away from registry?
Because you watch the census, and you, as the census goes up, right, like, Bellevue, right, our chief example, where it's running 200 census higher, right, there was a nursing plan, but that nursing plan is obviously
Obsolete,
inaccurate, the one that was created several years ago.
Yeah.
So we have to keep updating it.
Right.
But they have, within the nursing plan, there's ratios of patients, this many patients leads to this many nurses. So as they, show, okay, our census is higher, then finance can say, okay, then you should be hiring X more nurses to deal with it.
So there's gonna
And
be a
there-
lag.
Yeah.
There
that's
is
the
a little
lag.
bit of a lag.
Right.
Yeah, there is a percent in the model that allows for flexibility exactly of those things, like for coverage, like if people are out or they have vacancies. So there's still a percent of the model that includes temp and overtime to kind of be able to step in quickly until, to Dr. Katz's point, they
So you can hire the people,
or,
get them
put
on
through
board.
orientation, right? So there is always a factor of turnover that we have to account for a level of flexibility
Yep.
in the
Regi-
model.
Registry also has the additional issue that if the nurse doesn't show, you don't pay.
Mm.
The nurse doesn't come, the nurse doesn't earn any money,
Money,
right? Registry has no sick leave, vacation, anything else, right? Because we're not the employer. So the contractors provide, we are saying we want 8 hours of nursing. If they want to get paid, they have to give us 8 hours of nursing. Our staffing is not like that. We as a system have generous sick leave, generous vacation, and that's all good, but it does sometimes lead to people being on the schedule but not on the ward, which is why periodically, I get a complaint about, such and such only had 3 nurses and it's supposed to have 6. And it's a challenging
Managing the
problem. Well, there were
schedule.
6 who were on the schedule,
Mhm.
but there weren't 6 who arrived.
Yep.
In a registry setting, that doesn't happen.
Right. Okay,
Okay.
thank you.
Okay, and to add to that, we are also building the revenue budget out to align with those staffing budgets. So the period that we're picking up for revenue assumptions is the same period we're picking up for the staffing model assumptions. And as more staffing models are built in and you're hiring staff outside of those models, our PS budget will be better aligned with the actual activity. This snapshot just is going back to John's original point where despite the Change Healthcare issue, we are still year over year doing better on our revenue to the tune of 110 million, largely driven by, volume being up, but then also our rates being more favorable, including the UPL conversion rate add-on and our Medicaid rates. And at the same time, our volume is up, visits are up, and our CMI is slightly up, even though volume is up, which is rare. Any questions here?
Revenue cycle. So we're reaching the end of the recertification process. That'll wrap up with the month of June. And overall, our results are in line with the red line, our financial plan. The last June renewals will complete in August and September. And then after that, we'll go forward with our annual renewal process. So overall, our centralized telephonic financial counselor teams are really working on the outbound calls with our payer partners. And the facility-based financial counseling teams are working on upcoming appointments. We have work queues that sync with those upcoming appointments. Schedulers have a flag, providers have a flag, and the financial counseling teams have a flag to really alert them on when a recertification is not been conducted. And we're really looking for that positive interaction with the patient to get that recertification. We do have some headwinds, though. I mean, we have the dotted lines are the stretch goals. We've made it some months and missed it others, but the headwinds really are for H&H in particular, Metro Plus, is that we do have a lower recertification rate for patients that were auto-assigned to Metro Plus as a result of COVID. They came in for a COVID vaccine or a COVID test. We never had another connection with them after that. So very hard to get a recertification with somebody you don't have a meaningful connection with. And that was particular to Metro Plus, not as much on the Health First side. And then the other challenge is that we have increasing patient volumes, which is stretching the financial counseling teams, and we're addressing that through staffing. So overall, we're pretty proud of the achievement. Average 78% recertification rate through the end of April. We'll be wrapping up in August and September with those June recertifications, and then getting that annual, getting back to an annual cadence, if you will. So pretty good.
And that red line is what we budgeted at, is that the?
Yes,
Yeah.
that's the H&H financial plan.
And
we had a goal and then a real stretch goal.
Right, so it looks like our goal is about 80%, we're averaging 78, but our financial plan was assuming
75.
75.
76.
Great, thank you.
And then this is our Change Healthcare slide. So a pretty busy slide here, and I have it in 2 pieces, if you will, the cash impact and then that operational recovery. So it's been all over here. So we knew when that cyber attack happened, kind of dawned on us very quickly that we had a problem on our hands as it kind of unfolded in that first week. So we projected a cash shortfall when we realized we were not going to be able to send out claims, and there was no date to send out claims. So we knew we'd have a problem, and we projected a problem, and that problem came to be realized. In April, we were over $250 million behind our cash receipts, and then in May we recovered, and that was really because between February 21st and April 3rd, we could not send out a single claim. So we don't get the claim out, we can't get paid, was our problem. Then April 2nd, we're allowed to send out our claims, but we can't send out over 400,000 claims at once. We had to send them out over a 3-week period. We were sending out our baseline claims plus the backlog claims. So we sent out our claims between April 2nd and the 17th, 19th. We wrapped up our HB and our PB claims. So the cash receipts started to come in end of April, beginning of May. So by the end of May, we knew we had recovered our cash. So we're in a positive cash position. But that doesn't mean that the work is kind of concluded at this point, because we have not reconnected with all of our payers for the remittances. So although the cash is coming into our bank account, I don't know, and our patient accounting teams don't know where we've been denied. And that's our opportunity, is to find out where we were denied, appeal those denials, and then get more cash. So that's really a blind spot for us. For some of our payers, they're not reconnected into Change Healthcare to send us those remittances.
So those, can we address those through our Experian contract, or that's still being done?
Yeah, we're moving to Experian, and it is really a two-part problem in that some of these are coming in through Change Healthcare, and others we're moving to Experian at the same time. So it's, where is that remittance right now? Is it being sent by the payer to Change Healthcare, or are we waiting on it through Experian? We have our tracker on who we're missing and where we think that is.
Right.
And that's what we're waiting on.
And to the extent that those might get aged out, we have a good tracking on being able to recover any.
So that's where I'm pivoting to Megan, and Managed Care has been communicating with our payers, really requesting the leniency on timely filing. The big one is Medicaid, and Medicaid in the end on June 17th on or about then came out with a delay reason code. What we can the code we can append to our claims to say it was impacted by Change Healthcare, please, and they're giving us until August 30th. So, and then other payers, Health First in particular, has been very good with us. We were able to already send them a list of claims that were impacted, and then we'll track those receipts. So we are working through, what we're calling pockets of denials.
And we're following the guidance that was put out by Department of Financial Services. I mean, they asked plans and providers to work together, identify, where you had a batch of claims that were hung up, and we can track those, and we keep communicating, with those plans to say, please help us, and be patient with us, because we're moving between two systems, right?
Yeah. So is the way to track them just based on the date?
We've tagged every one of the claims. So we have a list of 420,000 plus claims that we've tagged, and we're running those claims to make sure that we're paid on those.
Right.
Or an adjudication as those remittances come in.
Okay. Thank you.
So that's our pocket. And then really on the operational side, the operational recovery, we have a lot of things going on. So Change Healthcare used to send our patient statements, our self-pay patient statements, and they quit that business. So we have contracted with another plan to send out paper statements. That'll be coming online shortly. Electronic statements we've already been sending out. We pivoted to that in early March. The clearinghouse side, basically sending out the claims and getting that cash back, that's up and operational. And then the eligibility side, we went through a series of processes, the manual checking, then we were able to send batch claims through Experian, and now we have real-time eligibility. The register can verify the eligibility right then and there, and that went live on 6/4. So we have some things to work out as we've come back online. We're optimizing our process, and that's going well. And then the claims are going out. We've been as I said, we've been submitting since April 1st. So really, the last connection is those remittances to make sure that we know where all those claims went and that we were paid appropriately on those. And that's what we're really going to be working through. Basically, we're looking at that as a summer project, and it's going to go into the fall just to make sure that we're all complete on that.
I've liked the new text messages about the bills. So I,
Hello world, yes.
started getting them in March. But I mean, it's a very, for a health system that wasn't very good at billing to get now a very clear, text, which comes quickly.
You're saying to the
Um,
patient?
Yes, I received my sister's because she doesn't have an email, so she uses mine. So I see and it's very clear, the cost of your visit is blah, 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 and it has been paid by the insurance. She's on Medicaid, and, the amount you owe is zero. Very clear, very prompt. So, good for you.
Good to hear that review. Thank you.
Sally, did you have a question?
No, I didn't, thank you.
Great, thank you. Okay, on the value-based side, this first slide here is documenting really outstanding performance that Health and Hospitals had in calendar year 2023 within our Health First value-based contract. You can see the first table on the left is just flagging some HEDIS measures that are standard measures that all health plans are tracking, and the green is just showing where we improved year over year. So there's a lot of green, and that's really an exciting achievement through a lot of outreach efforts that we've had, through just having tighter relationships with some of these patients in getting them to come in for care, and a lot of follow-up measures. So trying to build those pathways where a patient leaves the emergency room, what follow-up are we doing with that patient? So in the middle, there's a table showing that in Health First Network overall, on both the Medicaid and the Medicare sides of their business, many of our facilities were ranked within the top 5 or even the top 10 for overall quality performance. So that is tremendously impressive. And it manifests itself on the right in higher incentive earnings that we're bringing in. So you can see that bar has steadily been increasing since 2020. And this calendar year 2023 was our highest to date, and we really blew it out of the water. So that's very exciting. I think.
Yeah. I mean, I don't. We can't say enough about this.
Yeah.
Remember, Health First is not our plan.
Right.
Right. We are not the dominant provider in how many. John sits on the board. How many? We're in the top 10. How many? Program, I'm not sure, but it's not even hospitals because it's also clinics.
Oh, yeah.
Right. So it's
Tremendous.
right. I mean, so it's basically all the hospitals and all the clinical practices in New York.
Yeah.
And we are somehow,
5,
this number, 5 of the first 10 and 3, 6, 7 of 10 on the Medicare side. And I wasted no time in sending an email to Pat, and saying, wow, it seems like Health and Hospitals is doing really well in your model. And how about helping us a little bit on the housing front? We've had great success, with Metro Plus Health, with housing their clients. Wouldn't you like to help us, given our performance? And she said she'd be, happy to learn more. So I'm trying to, but it's just very, very objective, right? It's not us saying we're doing a good job, right? It is, a plan that is not ours, and we are not the dominant provider saying we're doing a really good job on quality.
Yep. The one thing to flag here on the financial end is that the incentive earnings that we are going to be eligible for in future years may be compromised. So specifically, the state, I think, halved the quality pool in the Medicaid program. And so there will be a point at which we're not going to continue to exceed the dollar amount year over year, because the pool of dollars is going to be compressed. But I think we can still aim to have, in that middle chart, as many of our facilities in the top of the quality performance, right, and still feel very proud of that. course.
Yeah, we would plead with the state and the legislature to restore those dollars. I mean, they're so valuable to us. Our whole model is based on really value-based payment. And
Right.
to the extent that we can earn our margin based on quality metrics is exactly how we're trying to build health and hospitals. So
Right.
for them to cut the pool, and that's, you know, they're cutting it year after year. So
Oh, it's a multi-year cut.
yeah, and I think it's only down to like $50, $60 million, and it should be hundreds of millions of dollars. Again, I just think it's the right way to spend government money is to let us compete on quality measures,
Right.
right? Because it keeps a focus that you otherwise will lose if you
Yeah.
don't have it there. And certainly it's got our focus, and we're performing pretty well.
And is the cut on the Medicaid side?
Yes. On the Medicaid side, but there are monies being added on the essential plan. So they're trying to balance it out a little bit, but those are two different populations. And
Right.
we would just ask if they can find the money to restore those pools.
Great. Well, again, congratulations. Very terrific work. Thank you.
And then last slide here is just a quick flag for the board about CMS final rules that were issued in April of this year. There are going to be a lot of policy changes for us to be monitoring over the months and years to come. So they issued in April both a Medicare rule and a Medicaid and Child Health Plus rule. And on the Medicaid side, there will be new standards for enhancing access and quality of care that we will just need to monitor in the context of our value-based contracts to make sure that we are meeting those new compliance standards and continuing to excel in quality. There are also significant changes to the way that CMS is instructing that Medicaid state-directed payments work, and our UPL conversion that we've been talking about is a state-directed payment. So we just have to monitor that and understand the gives and takes with that. On the Medicare side, something that I know that Health First has top of mind is that there will be some requirements that Medicaid managed care plans who offer a Medicare dual special needs plan will need to coordinate all of the benefits on the Medicaid side and the Medicare side for a given member. And largely, New York State hasn't been terribly sophisticated in being able to coordinate all of those benefits. They have done a really good job on what they call their Medicaid Advantage Plus program, which are very specific Medicare programs that the patients require long-term care needs. And so the Medicaid benefit gets carved into that premium, and everything is kind of holistically managed by the plan. But there are members who could be on a dual SNP or D-SNP that continue to get their Medicaid paid by Medicaid fee-for-service. And so this is CMS trying to create a little bit more continuity across the managed care plans. But in New York, I think that will be specifically challenging for large Medicaid managed care plans who do have patients that are covered, their Medicaid benefit is covered, for example, by Health First, and they need to be enrolled in the D-SNP. So it's just going to be require a lot of state coordination in the enrollment process. And I think that there are certainly concerns on the Health First side that we don't want to lose membership or be confusing to patients in terms of what this requirement will be. So this is just a very high-level snapshot of some of the anticipated impacts we think that we'll be monitoring, but I guarantee there will be more to add to this list as time goes on.
And this is, these things will take effect immediately?
2027. So we got time on most of these. They pushed out, the dates, and it'll take that long. But I applaud CMS on their rule. I think, in many ways, I think we're built to be a good partner, I think, with CMS to implement all aspects of the rule. And the D-SNP one is a hard one. The state's been at it a long time. When you got a lot of people that are fee-for-service Medicaid, and they're a tough group. They could be SSI disabled, right? We have to understand who they are, what services are they using. But to me, it does make sense to coordinate both the Medicaid and the Medicare together. And then, at-risk relationship. It's just going to require some change and some thoughtful thinking and partnership with providers and plans to get it done. And I think between now and I think I got it right, 27, right? There's enough time to do this, and I think it'll benefit the patients in the long run. So, but there's a lot here on this one slide for to keep us busy for a while, right? Yeah.
And the Medicaid state-directed payments, does that affect us?
Yeah, no, it definitely does. As Megan said, we use the state-directed payment, process to do our UPL payments.
Right.
And I think CMS again has come up with, I think, some very good approaches to allow us to perhaps even expand beyond using the UPL as the benchmark. But they also have, requirements on, value and producing, good outcomes. And there's also timelines associated with this that I thought were also reasonable. So I see opportunity here for us as well. UPLs have really been, fantastic in terms of, keeping the financial plan in balance. And so we have some work to do on that. And that may, that will come sooner than
27.
Yeah.
Right. Okay. Thank you.
Yep. We'll keep you posted there.
Sally, any questions?
It's dizzying.
It is.
Yeah.
It is. It is.
Someday I'll know what each of these mean,
Yeah.
and I don't right now.
Okay, so for this part, and John touched a little bit earlier on this, so right now we are basically in the last, jumping back to our budget planning for 25, now that we're actually in 25. This is the last phase, phase 3, which you probably guessed by now is both feeding into our initial budget, but also in our modified budget as the fiscal year goes on. You'll see a list of areas and strategies that we're going to be focusing on for fiscal 25. Some of these initiatives we will be developing throughout and strengthening throughout fiscal 25. There are some revenue cycle initiatives where, as it says, we're going to be raising the bar a little bit more there, where there are opportunities. We're in discussions with the facilities right now to kind of wrap up areas where we have opportunities for organic growth on the outpatient side. For specialty services. So again, as we speak, we're getting some responses here. Some of it will be ready enough to go in the initial budget. Others, will continue the discussion there. More business plans that emphasize a little bit more of the cross-facility partnerships. So we have the OR efficiency and expansion, which goes hand in hand with what we mentioned earlier with our OR model now being rolled out in fiscal 25. So it's timely to look at that. We're going to be looking at oncology services across the systems and the facilities, and have a few plans in the works that are being developed there. John mentioned the physician workforce plan budgeting and the investments we make there so that we can have more stable clinical services model, less reliance on locums there with its own glide path. And then the other piece, as our volume goes up and the demand goes up on our system, there are pockets and areas that we are going to be targeting. For example, the length of stay, work on where there are opportunities to reduce that, where there's a lower level of care, and so more to come in that area. Overtime management, Salima touched on that in the variance against budget. The way we tackle that is with more models to be created, so we have the right mix of our full-time staff and flexibility of overtime where needed. And we touched also on the temp agency continued glide path through December for nursing, and we're also tackling all other temp agency staffing there too for this fiscal year now. So more to come here.
Yeah.
Thank you.
We're close, right? A couple weeks away from wrapping it up. Is that our target? You guys done a great job there. Yeah.
For the FY25.
Yes.
Yeah. Good.
I just had a question on the dental benefits. What kind of money? It indicated that we haven't on Change Health that the claims, the dental claims,
Oh, dental benefits.
dental benefits.
Yeah, the reconnection with Change Healthcare and Experian. Yeah, dental has been a problem. We haven't dental just reconnected on the 25th, 26th. So we'll know how we did that. It was just Change couldn't reconnect on dental, and then we'll reconnected with all of our managed care plans on the 25th. We'll reconnect with Medicaid on the 15th, I think. And it's just been a struggle on the dental side. It's really been very difficult for us. So we have a big AR. We'll get those claims out and come back to Experian. So we'll have a bit of a recovery on the dental side, on the PB dental.
Well, appreciate the update. I think, Dr. Katz,
Yeah.
any other
Nope.
comments? Good work managing through a lot of challenges in fiscal '24. It sounds like we ended okay, and planning for '25. So,
Yes.
thank you.
Thank you.
All right.
Thanks.
If there's is there any old business or any new business to come before the committee? Nope. There being no further discussion, meeting adjourned. Thank you.
Hey, John, can I cut you?
This meeting is no longer being recorded.